Welcome, everyone. Well, welcome to our webinar today. As we await for the rest of the members to join in, I wish to welcome everyone for this very important conversation. We'll just give other members the next 3 minutes to join in, then we'll proceed from there. Thank you so much for joining. Thank you so much for joining. Uh, I can see we are quite a good number and more are still joining. I wish to start this conversation with the introduction. From our participants list, I can see Mr. Richard Kaketo, Mrs. Beatrice, Dr. Maria, welcome. Georgina Muthoni, you're welcome. Ivy Kuira, you're welcome. Karaoke Wangoi, welcome. Mr. Kevin Yoga, karibu sana. We're still waiting for more panelists to join us. Maybe I can give them the next 2 minutes, then we'll proceed. Thank you so much for joining in. Welcome to our webinar this evening. My name is Joseph Kashina Irongo, and I'm happy to host you for this webinar today. This week, Kenya Christian Professionals Forum is hosting the Life Week, and this Life Week is will be held. Sorry for this. Just a minute. This week, KCPF is celebrating the Life Week by hosting 3 events that we are planning to do this week. These events include tonight's webinar. On Wednesday, we'll be having the Life Symposium at Cardinal Otunga, and on Saturday, we'll be hosting the March for Life 2024. These events are crucial in the protection of life and the influencing of policies in this country. Tonight, we intend to discuss largely on our theme today, which revolves around making the reproductive health policy work. Today's discussion largely entails a deep reflection on the progress that we have made in the implementation of the reproductive health policy, as well as reflecting on the future of the policy and how it will influence the activities, the future of the reproductive health in Kenya. Tonight, we are joined by I can see two panelists with us. The first panelist being Dr. Gideon. Karibu sana daktari. Thank you for joining us.
Asante sana.
You can hear me, right, Dr. Mutua?
Yes, I can hear you. Can you hear me?
Oh, yes, I can. Karibu sana.
Asante.
We are also joined by Dr. Kaliti. Dr. Kaliti, karibu. Can you hear me? I had seen her on the panelist. She had joined. Dr. Kaliti, are you with us? Dr. Kaliti, are you with us? We also have Dr. Wahome, who will be joining us later in the conversation. We anticipate a great conversation in regards to this discussion tonight. Maybe for a start, I will also recognize Mr. Kaketo, who is the live committee convener. Mr. Kaketo, can you hear me?
Glad to be here. I'm in transit. I may not be able to speak a lot, but welcome to all.
Asante sana. Karibu sana. We also have Mr. Yoga. Mr. Kevin, can you hear me?
Yes, Joe, I can hear you. Thank you for joining, everyone. We look forward to a great discussion.
Thank you so much for joining us, Mr. Kevin. I would wish to recognize other participants in this meeting. However, allow me to proceed with the session so that we are on time on this discussion. I wish to recognize Mr. Kaliti. Mr. Kaliti, have you been able to join the meeting? Okay, it seems he has not yet been able to join, but I will proceed. Daktari, Mr. Gideon, karibu sana. Maybe you can start us off this conversation with telling us a brief history of this, the document that we are discussing tonight, the reproductive health policy. Where does it come from and why do we need it as a country? Mr. Gideon.
So thank you very much for this opportunity and for just giving us, myself as a panelist and also the participants, just an opportunity to reflect on the National Reproductive Health Policy 2022-2032. And just as a way of beginning is just to mention that the National Reproductive Health Policy 2022-2032 is a policy that follows the previous policy that had been enacted before by the government of Kenya. So before this policy, we had what we used to call the Reproductive Health Policy, 2007 up to 2015. So up to 2015, we had a policy that was in place to guide matters of reproductive health in this country. Well, of course, the reproductive health policy does not stand in isolation. It derives majorly from the main policy of the government of Kenya and of the state, which is the Kenya Health Policy 2014-2030. So that is the overall policy that guides matters of health at both levels of government. That is the national government and the county government. Of course, a policy binds all actors at the two levels of government, the public and the non-state actors. So that is where this policy is coming from, largely drawn from the Kenya Health Policy 2014-2030, and as a follow-up of the policy that was there before, that lapsed in 2015. But in addition to that, colleagues and friends, is just to note that this policy also derives a lot from the other, frameworks in this country. We are talking about the Vision 2030. We are talking about the Constitution of Kenya supremely, because that is the supreme law of the land. And in fact, this National Reproductive Health Policy quotes a lot from the Constitution of Kenya. So, and this policy was made in a consultative manner, where there was robust public participation from the grassroots to the counties, to partners, and all medical associations, and even grassroots organizations, and even the partners, development partners also had an input in this document. Thank you very much.
Thank you so much, Mr. Gideon. Just to clarify, there has been conversation going around that there was no public participation in the development of these documents. Just to clarify, was there public participation, and were civil society organizations involved in the production of, or in the development of these documents? Was there participation? Mr. Gideon.
Yes, thank you. I think that's an important question.
Yes.
And a valid point, because the Constitution of Kenya really stipulates that for all documents that we need to do as a country, there must be public participation from all sectors of the society. And the formulation of this document duly followed that procedure. Of course, the first thing that happens when a country is formulating a policy is, of course, to look at what has been done so far with the other policy and the Kenya Health Policy framework, and then go to the grassroots. And in this case, of course, you understand that the counties form a very important role in any policy formulation and, of course, implementation. So all the counties were involved. Yes. The 47 counties were involved, and members were called to give their views with regard to what they would like to see put in the new document. Yes. And various meetings were held for a very long time. And in addition to the counties, there are also other organizations that were also involved. Yes. In this process, yes. Including international NGOs. UNFPA was part of this document, as well as other organizations. At the formative stages, the World Health Organization was also involved in the formulation of this document. And all the 47 counties, like I said, were also involved, including, of course, the Council of Governors, specifically the Committee, for Health, and so many organizations, AMREF, and many others were actually, involved in all this, formulation of the document. And I might even add that even at the very final stages, several meetings were still held, some in Mombasa, where various groups again came in just before the validation of the document. So we had even people, representing what would be regarded as intersex. We had a participant from that group. We had youth groups. And basically, I would say that this is a document that followed all the due process with regard to formulation of our policy. Thank you.
Thank you so much for this clarification. Again, thank you for your insight on this matter. Just to welcome other members who are still joining in. Karibuni sana to this webinar. We've just started with a word from Dr. Mutua. Just to check in, is Mr. Kaliti able to join? Mr. Kaliti, are you with us tonight? He seems to have trouble with joining, but we shall proceed. Just to take note of our webinar tonight, we are missing on, we are currently, we do not have a representative from the Ministry of Health. Just to clarify, we were unable to reach, to have one on the panel, but we will proceed and get insights from the panelists that we have. Dr. Gideon, I'll still get back to you as we wait for Mr. Kaliti to join. From your experience, what is the state of the reproductive health services in Kenya? From I understand that you're a gynecologist. The first word really troubles me in the pronunciation. Maybe you can help me with the pronunciation of the first word, Dr. Gideon.
But you mean the obstetrician?
That one.
Yes.
Let me just say obs. Or do I use the second word?
You can just say obs-gyn or a gynecologist. That's okay.
Let me use the gynecologist. Thank you. So my question to you again, what is the state of reproductive health services in Kenya? I know you are at the forefront in this, owing to the fact that you are a gynecologist. What is the state of the reproductive health services delivery in Kenya at this point?
So thank you very much. Even as we wait for Dr. Kaliti, who is from the Ministry of Health, yes. Maybe allow me just to mention that as an obstetrician gynecologist, I'm also the Nairobi City County obstetrician, OBS-GYN. Yes. I do not, of course, represent the national government, but one of my duties is to be the County of Nairobi obstetrician gynecologist. So, of course, even as I speak in this forum, of course, I'm not essentially representing the county, but I'm also going to give a perspective. As somebody who works at the county level, and even previously having worked at the national level in the Ministry of Health. So basically, to answer your question very, very quickly, when it comes to reproductive health services in this country and where we are, there are various indicators that are used to track the progress of reproductive health services in this country, and which are quite well elaborated even in the National Reproductive Health Policy. So where we are right now, one of the most important indicators is what we call the maternal mortality, rate or ratio. So basically that tells us how many mothers, die while giving birth or when they are pregnant. So basically where we are at as of now as a country, we are at 355 maternal deaths per 100,000 live births. That is where we are, 355 maternal deaths per 100,000 live births. According to the KDHS, that is the Kenya Demographic and Health Survey 2014, we were at 362. So you can see there's a slight drop. There's a slight drop. And then the other thing also to notice is that the other indicator that is also quite important is about skilled birth attendance. So what we mean by skilled birth attendant is that if a mother is about to deliver, and they have somebody who is qualified, who can, assess the mother, know how she is doing, how the baby is doing, and then safely conduct a delivery to have a safe, a healthy baby and a healthy mother, in a safe environment. And that indicator, what we call the skilled birth attendance, in according to the KDHS 2014, we were at about 60%, about 62%. Currently, as we speak, as a country, we are almost at 89%. We're in the 80s about that. So that is on that aspect. There's been improvement, because it means that many of our mothers, they're able to deliver under the care of somebody who is trained. Then the other important indicator is basically the issue of ensuring that our mothers attend antenatal care. So in the 2014 KDHS, we were at 58%. That is the mothers who attend the antenatal care up to the 4th clinic. We were at 58%. Right now we are at more than 70%, and our target is actually 70%. So that is again a target that we have been able to achieve. However, having said that, it's just to take note of the fact that one of the things that the country has done is to have the issue of Linda Mama. Basically, that means that any mother who is coming to deliver, especially in a public facility, can deliver, and then the government takes care of that through the Linda Mama program. We are aware that in the current dispensation, the government has taken that into consideration and is morphing even the Linda Mama to be done, in the whole umbrella of SHIF. So again, it's the same principle, it's the same policy guideline, that when a mother is delivering, they should not be asked for any money, or rather the government is able to, undertake the cost of delivery, because that is important, because we know that many of our population, actually a considerable number of our population live below the poverty line. So basically that is where we are largely. But also to mention that one of the important things is that, of course, you cannot track progress without targets, and the targets can only be set by the national government through a policy. So I would say that even by the fact of having a National Reproductive Health Policy, that means that we're in a good place, because we have a document that has the targets as the baselines that have been done. It has the targets according to 2030, when when Vision 2030 comes to an end, and of course also according to what we call the Sustainable Development goals. So that's basically where we are at in terms of reproductive health, in this country, basically in a nutshell.
Okay. Question. Just a question to clarify. There is a shift taking place from NHIF to SHIF, and Linda Mama is part of the program that was taking place in the NHIF program. Is it being done away with? What will happen to the program that really helped mothers who couldn't afford these maternal care? What are they carrying on the program to SHIF, or it's being done away with?
Yes, thank you for your question. Actually, before I answer that question, is just to let us know that the government of Kenya has embarked on universal health coverage. You are aware that the president has been very keen on it, and this is actually a global commitment that the government of Kenya has made, and all the 2 levels of government and partners are on board in this particular aspect. So basically, universal coverage wants to ensure that people are able to access services without suffering, financial ruin, so that then, they don't incur what is called catastrophic expenditure. So basically, under that policy guideline, it also means that Linda Mama cannot be done away with. Actually, what the government is doing is to put Linda Mama now under SHIF. Remember that when Linda Mama came about, the payment was being done on its own, but again, the government was able to put in a structure such that now Linda Mama, the monies were being paid through NHIF.
Yes.
basically so that they can be a structure. And therefore, if NHIF is, being replaced with the chief and the others, it also means, of course, that Linda Mama has a safe place. The government of Kenya cannot do away with ensuring that mothers are able to deliver without incurring, undue and unnecessary financial burden. That is a commitment of the government of Kenya. So there should be no worry. Of course, there will be a few challenges here and there as the implementation of SHIF comes into place, but it is good for people to be aware that the government really is keen on that. It's keen on the fact that mothers should be able to deliver and not suffer, that financial, barrier to access to healthcare. Thank you.
Thank you so much for that clarification. Just to check in, Mr. Kaliti, are you with us? Mr. Kaliti, are you with us? He's been having a challenge with joining. Mr. Gideon will allow me to continue as we wait from Mr. Kaliti. Dr. Wahome will also join us later on. He had an engagement that was ending at 8 p.m. Hopefully, he'll be able to join us for this conversation after his engagement. Dr. Mutua, another question for you. When we talk of reproductive health, what does it really entail? Because from the conversation we've just had, we've mentioned about maternal care, we've mentioned about pregnancies, we've mentioned about being able to get quality services from a professional. I would love to just clarify with you, what does reproductive health care mean in the Kenyan context, and maybe in the general context globally? Dr. Mutua?
So thank you very much for your question.
Yes.
So basically, you're right in the sense that, reproductive health does not just mean maternal care.
Yes.
However, it is one of the most important, indicators.
Yes.
Even universally, we say that the state of maternal care in a country is the key predictor of the public health services of a country. That is globally. However, just to answer your question very fast. So basically, reproductive health has several, areas. And let me just quickly mention those areas. So you have, under reproductive health, you would have, of course, you talked about issues of maternal and perinatal health.
Yes.
Basically, that means how do people access antenatal services? That is when they are pregnant, and even before they are pregnant is what we call the preconception care. So how do they attend antenatal services, and then how is the delivery, carried out? What I talked about, skilled delivery. Then after that, how is the postnatal care? Meaning after the mother delivers, what is the care given out to this mother? So postnatal care, and also there's also the care of the baby. Then in addition to that, there is also the issue of adolescent reproductive health. So that basically means then what are the needs, of the adolescent? What are their reproductive health needs? And of course, we are talking about issues of, menstrual hygiene and menstrual policy. We are talking about, ensuring that the adolescents are protected. That means that under this policy, that you cannot give, services to a minor without ensuring that a parent is there. And that is, of course, stipulated in the laws of Kenya. So we are talking about, adolescent reproductive health and the youth reproductive health, because you realize that in those very unfortunate circumstances where, we may have a teenage pregnancy, then what measures are being put in place under this policy to ensure that is taken care of? Then, of course, there is the issue of family planning. That is another parameter of reproductive health. Family planning basically means how do we, manage families? How do we know the number of children to have, how often, and all that. All those are issues of family planning, and family planning contributes to, population health and the numbers, the population of a country. So then again, in addition to that, there are also, issues of gender, in the sense that as we offer services in the reproductive health space, we realize that there are many issues that can come in. We're talking about issues of sexual and gender-based violence. So that is again taken care of in this policy in reproductive health. Basically, what the government has done is to ensure that what are called STBV services are basically offered essentially free of care. There's a toll line, even for that. So that is also part of the reproductive health. Then, of course, there are issues of HIV/AIDS and sexually transmitted infections, because especially, of course, because mothers can get HIV, or they can, get pregnant when they have HIV, AIDS, and of course, the chances of, transmitting, the virus to the baby are quite high. So first of all, ensuring that any mother who is getting pregnant, we test whether they have HIV or not, and then we are able to give them medicine and follow them through, and also ensure that as soon as they deliver the child is also, given, medication. And then other than that, of course, there's also what we call the cancers of reproductive organs. In our case, basically under reproductive health, majorly we are talking about, cervical cancer. We are talking about ovarian cancer, cancer of the ovary. We are talking about endometrial cancer, that is cancer of the uterus. Plus, there are also other cancers of the vulva and all that. Then there's also another important parameter, which regards to issues of infertility. So basically, we are talking about couples who are not able to have a child, or they take long before they have children. So that issue of infertility, and again, what is called sexual dysfunction, is also taken care of under reproductive health. So you can see that there are various, parameters in all that, and all these are quite well elaborated in this National Reproductive Health, policy. Thank you.
Thank you so much. That's quite a comprehensive outlook of the reproductive health policy. You've drawn me to a very interesting conversation regarding the triple threat. Our adolescents have really been exposed, and by exposure I mean we have a lot of information that is reaching them, and unlike the past, they are having very deep conversations about their reproductive health, and owing to the fact that they now are aware of what it entails to when we are talking about reproductive health. There was a conversation that was discussing reproductive health for adolescents. From my review of the reproductive health policy, I have noted that it takes care of this issue of reproductive health services for adolescents. However, there is a problem, or there is a conversation going around that the document does not really care, for lack of a better word, for the reproductive health of adolescents, especially when we talk about the age it has captured to be the age of 21, which it has captured to be the age where they are aware of their reproductive health. What is your experience interacting with adolescents in regards to access to reproductive health in hospitals that you have been to?
So thank you very much. I think that is important. It's something that we have to discuss, and it has been discussed extensively at various levels and with various stakeholders, and that's important. When you talk about the triple threat to the adolescent and teenagers, of course, we are talking about, first of all, the HIV/AIDS.
Yes.
We're talking about pregnancy. And you're talking about the issues, of course, of sexual assault. That is the gender-based violence. So basically, how this reproductive health policy addresses issues of adolescent health is, first of all, to ensure that it works together with other sectors of the government, other ministries. Because remember, this is the Ministry of Health does not work in isolation. So basically, one of the most important things that the government over the years has been able to do is what we call the 100% transition. So the 100% transition from primary school to secondary school addresses the issue of what can happen to these young girls and young boys when they are at home. So basically, it ensures that, and we've seen the government is very keen on that, to ensure that every county, every sub-county has targets. Basically, after class 8, the government wants to know where are these children. So that 100% transition has really been very, very important. And this reproductive health policy, borrows heavily on that because they are in what are called the safe corridors. Because we know that when they're in school, they are more or less in a protected, area. They are kept busy. And the other thing also is that, with regard to that, is that when they're in school, there's also, education. There's what we call the school health, policy. And in fact, Dr. Kaliti has a lot of experience with that. And I can see he's actually, joined us. Basically, what that means is that through this policy and other ministries working together, ensure that there is actually a content that is given to our children, in school about matters of, education with regard to, sex education and all that. But they are done in a way that, honors and uplifts and safeguards the national values, of our country. And you realize that even before, people would be taught about, biology. They will be taught about, sexual organs and stuff like that. If you look at the curriculum, even in the primary school, they are being taught about HIV/AIDS, how is it transmitted and all that. So basically, all that is encouraged through this reproductive health policy. So you can see the policy is not silent on issues of adolescent health and even issues of teenage pregnancy. And then in addition to that, one of the things that this policy has done, which was not in the other policy, is that it talks about issues of pregnancy, crisis pregnancy. So crisis pregnancy means that this is somebody who gets pregnant, and especially we are talking the context of adolescents. And of course, under those circumstances, they are not, they are not, of course, ready, even physically, to be able to get a child. They are not prepared. They do not have the resources. They are not married and all that. So this policy takes cognizance of the fact that there's what we call the crisis pregnancy, and therefore, what does it mean? What does it entail? And basically, it calls for the fact that the government of Kenya, through the Ministry of Health and other stakeholders, will ensure that there are various stakeholders and options that are being given, to these people when they become pregnant. Basically, it also means that when a teenager becomes pregnant, you see they are taken care of in terms of the antenatal care, and of course the delivery, and of course postnatal care, and of course in addition to that, of course there's a program for ensuring that these children go back to school, so they are not left on their own. They are not left on their own. Then, with regard to access to reproductive health services, what we are saying is that, for instance, if by bad luck, or that unfortunate incidents. At times it happens in our society, or really not really bad luck. I mean, this is basically children who are defiled, because we need to call actually teenage pregnancy. We are talking about defilement. It's not even really bad luck. I should withdraw that. So basically, even when that happens, the government ensures that services are offered, to these children. They can come and deliver. They are taken care of. And if it comes to the time of, let's say, there is a need for the cesarean delivery to be done through an operation, it's clearly indicated what can be done, who can give consent. If the parent is not there, then a senior doctor can give consent for this child to go to undergo an operation. Then, of course, the other services that will be required, let's say you have children who come and they have what we call heavy menstrual bleeding, because of what we call hormonal imbalance. They come, of course, to the hospitals, and they are taken care of course, under parental guidance. So we take care of them, we tell them what is going on, and we of course discuss with the parents and ensure that even when they go back to school, that even the teachers, particularly the ones who are in boarding, they will know that maybe these children have some other medication that they might be using. So there's a plan, there's a policy, there's a program that the government has put in place to ensure, one, that the adolescents have access to reproductive health services, that there is reproductive health education, that we work with other ministries to ensure that children are taken care of, like the administration, and also the Ministry of Education and other state actors. So basically that is how I would answer your question. Thank you very much.
Wow, thank you so much for such a detailed explanation to my question. I wish to recognize the presence of our board members, Mrs. Beatrice Kitui and Francis Wambua. Karibuni sana. Thank you so much for joining this conversation, which is very timely. I also wish to recognize Dr. Kaliti. Welcome to the webinar, sir. Sorry for the trouble with joining in. Can you hear me?
Yes, I can hear you. Thank you, team. And I'm happy and I'm following. Thank you.
Thank you so much for joining us. And I think I'll just go direct to the first question that I'll ask you. From where you sit, you've been through the process that actually came up with this policy, the reproductive health policy. What were the objectives tied around this policy? What did the developers want to achieve when they were coming up with this policy? Dr. Kaliti.
Thank you. That's quite a broad question, but I try to summarize and address it in very plain language. One, the Constitution of Kenya guarantees the highest attainable standard of health care or status, including reproductive health.
Yes.
And this policy was basically developed to be able to realize that right for every Kenyan. So the overarching objective of the policy and in tandem with the Kenya Health Policy was basically to make sure that every Kenyan, the 50 million plus, they're able to attain the highest attainable status of reproductive health within that space. Yeah. Other than now, we can go to the finer details, but that is basically the guiding principle.
Okay, thank you so much. And as we also have that conversation of the objectives of the policy, there was one of the objectives highlighted in the reproductive health policy is the universal coverage and comprehensive reproductive health services. Can you explain to us what it actually means? The universal coverage of quality and comprehensive reproductive health services.
Thank you. We are in the era of, and I think you've had a lot of that discussion because part of this was also futuristic because we're in the era of trying to create equity and make sure that everybody can access health services and healthcare, including within the space of reproductive health. So that universality means that everybody within their space and within within that space of limits of their reproductive health enjoyment, then they should be able to enjoy full access to services that are, tailored to their needs, not to the extent that they speak to the highest attainable standard for that particular aspect that you're talking about. So the universality was basically making sure that no one was left behind within their needs, and those were taken care of in tandem with the law and with the culture and the fabric of the Kenyan population. That is basically what that was meaning. That policy speaks to each and everybody.
Okay, we are just from having that conversation with Dr. Mutua, and he has really delved into the what the policy says about access to reproductive health by adolescents. One of the major concerns with by people, different organizations and individuals, is the cap that has been placed on the adolescents that allows them to only get reproductive health services at the age of 21. Unlike what the Constitution talks about, attaining the age of an adult age at 18. What was the rationale when coming up with the age of 21 in in allowing access to reproductive health services for adolescents and young people?
One, I would like to see that specific the way we framed it in the policy. I must admit I do not have the policy right hand now, and of course the transition I've been managing other issues of school health. So I might be a little bit off from that space for now, but I'd like to see the way we framed it. But I want to put it very broadly. Number one, the age of majority in Kenya is 18 years. So anyone below 18 years is a child. And I think Dr. Mutua has put it pretty well that the Children's Act is pretty clear that carnal knowledge with anyone who is below the age of 18 is not admissible in law, and the law does not enforce such a situation where a minor is engaged in matters of sexual or matter of sexual exposure or reproduction. So it does not mean that does not happen against the law. It happens, and there are avenues of being able to address that. But the policy and the law cannot endorse criminality and cannot allow that or turn a blind eye to that. Now, that will not be in tandem with what the Kenyans wanted. About the age of 21, it is about cognitive development. And one of the things is that we do have a lot of science that is out there that the developing mind has a lot of layers of transition along the way. And there are those changes that occur from the time you are born. When you are born with what we call the limbic system, that is basically drives the immediate desire, the immediate need, and is usually unhinged. And then as time goes on, there's a transition that occurs primarily during adolescence, and that transition to what we call social competency, and social competence where you can comprehend the permanence of the decisions you make and the sequelae that attain with that. Science has shown that complete maturity and evolution occurs after the age of 21 or 21 about. So if there's a mention of 21, it must be within the realm of cognitive maturity, because sexual decisions are decisions to be able to reproduce are some of the highest cognitive decisions a human being can make. So they require a lot of competence to that, because there's another life that is involved. There's a lot of responsibility, and it can also be able to derail one's pathway if it is handled or mishandled carelessly. So those are the things that we need to put into perspective. And I think it's within that realm that the number 21 comes about, because it's all about cognitive development and the competency be able to make sound and reasonable decisions when it comes to matters of reproduction and matters of sexuality per se within that space.
Okay, thank you so much for that clarification. Maybe
just to add, if you might allow, maybe just to add with permission of Dr. Kaliti. Dr. Kaliti played such a vital role in the formulation of this policy.
Yes.
Of course, is now involved in many other issues, also in the Ministry of Health.
Yes.
So basically, I think what he's saying is in keeping with what the document talks about. But like I said, there's a whole almost basically a page and more even on this document on all those issues of adolescent and reproductive health. So basically, that is even in page 12. Basically, what it says that there will be structural prevention interventions for the adolescent, such as protection from pornography. Basically, what that means is that issues of and that's why you've heard the government as usually ensures that children do not have access to any materials that might lead them to basically talking about adult content. So children should not, they must be protected from pornography, that keeping children and young people in school, as we talked about, or gainful engagement. And that means basically you've heard what the government has been talking about, that there is also a very big component of all the services that the government wants to offer, including tenders and whatnot, is basically towards the youth. And this of course
maybe sorry, Dr. Gideon, maybe
yes.
Sorry to interrupt, because I know I just in case I fall off and just in case I forget, you have heard a lot about this reproductive health policy and the rights of adolescents and all that. But let me say it loud and clear to everybody. The highest right that you can give a child of 18 years and below in terms of sexuality is protecting them from sexual abuse and carnal knowledge. That is the first right. It's a cardinal right. So when people are discussing the issue of rights, whether it's an issue of family planning or whatever, please always remind them the Northern Star is that number one, this is a child. And the first constitutional right you can accord them is to be able to protect them from carnal knowledge, exposure to indecent material, like Dr. Mutua is mentioning, and also being abused sexually. I think that is the first principle right. And then after that, the others can be drawn below that. If people get that clarity, I think it will resolve a lot of this confusion that we are seeing around.
Thank you so much for that clarification. Dr. Mutua, have you completed? You can.
Yeah, I think more or less. I think the other thing we're just talking about are issues of, safe houses, for minors. Basically, what this means is that if a 16-year-old comes and they are pregnant, then of course the government in the facilities must ensure that this child does not go to that environment of being abused, as Dr. Kaliti is talking about. So, and there's of course justice for minors. I think even now as we speak, I think there have been elaborate measures that have been put in place even to have and to fast track cases of child molestation in the judicial space, and what are called the SGBV survivors in the country. So, but what is important is actually what Dr. Kaliti has mentioned. He has mentioned that the most important thing is to prevent this child from being sexually, abused. And once you're able to do that under the various programs and the laws, then of course you're in a good place. Thank you very much.
Thank you so much for that clarification. Moving ahead, maybe I'll ask this I will ask this, Dr. Mutua. What are some of the challenges you have encountered in delivering reproductive health policies to special groups, such as those who are differently abled, such as the intersex people in our society? What are some of the challenges that you encounter in delivering the reproductive health services to these special groups? And how does the reproductive health policy suggest in resolving these challenges?
Yeah, so basically, I think that's a very important question. I think basically just to mention that it's not just the reproductive health services that at times are a challenge to those who are, differently abled. It's virtually many services are a challenge to be accessed and to be rendered by the people with persons with disability. But having said that, even in the reproductive health, space, there are various challenges. But I think what is important is that this policy takes cognizance of that, and therefore calls for measures to ensure that persons with disability are able to access services. First of all, of course, engaging with other, partners for that, for health education and general education. First of all, for people to know that if a person, persons with disability, that first of all, the same government, through the government facilities, is able to ensure that they're actually registered. So there is an elaborate registration, process for persons with disability in government, places, because that's the first place to do. So that once they are registered, then they're able to access services, not just reproductive health services, but other services, because they have tax concessions. They are they can access very many services free of charge, of course, including the reproductive health services. So there is that space, of course, issues of the health education, issues of ensuring that the services actually recognize that. And actually, in a number of places that we have, of course, knowing that that's a challenge, a number of facilities have put in place, measures like when you go for parking, there's places reserved for persons with disability. Anytime we are talking about how do you conduct a delivery, for instance, with a person with disability, there are ways that in which you are able to actually, conduct a delivery for such, for such a person. And of course, there have also been measures that have been put in place, even to have services such as interpretation. Some of the facilities we work with, they're actually people who are able to, they can do sign language and all that, so that when you have a mother who has come, say they are deaf, then you are able to, they can actually be taken care of. So that is what this policy talks about. But of course, there are actually challenges that we encounter, because many of our facilities, the way they were put up, structural modifications, of course, is needed to ensure that they actually access services rather fast. Because if you just have a maternity that is upstairs and there is no lift, for instance, you only talking about stairs, then that becomes a problem. But many of our facilities, I might even speak about Nairobi, the Nairobi City County. What we've seen is that the recent maternities that have been put in place, most of them, they are in the the ground floor, and in fact, even the ones that are even in the upstairs, there's there's a ramp where people can go and all that. So basically, it's a challenge, but this policy takes cognizance of that and therefore puts in place measures to ensure that persons with disability are actually taken care of. You've talked about the issue of intersex. Let me mention it because it is important. But also to just mention that intersex is actually just defined very well, because intersex, these are people who have a congenital anomaly. Basically, that means they are born with that issue. It's not easy to get to know. The sexual organs. At times it becomes a bit confusing to determine whether it is actually a male or female. So this is actually a congenital anomaly, and there's a way in which it's actually been defined, and there are measures that have been put in place to ensure that such people are well taken care of, so that even as they are managed and they are treated, there's a place, for them, because they often require, long-term care. They require what is called, shared decision making with not only themselves but also, their family members and their, parents and all that. So there's a place for that. And maybe just to throw a caution, because we know what has been happening in this country is that people have been using the issue of intersex to say there's actually there's a third sex. That is not true. Biologically, there is either male or female, and that's a biological, fact of life. That is scientific. XX, XX, XY, and all that. Of course, you can have a few challenges in terms of just the chromosomal aberrations and malformations and all that. But basically, there's no third sex. People have used the issue of intersex to say now there's a third sex, which of course we know they want to use that as a backdoor to introduce the issue of the issue of the LGBTQ, so that then you say, me, I'm not male, I'm not female, I'm non-binary. In fact, the term people use nowadays is non-binary, which of course is a misnomer. You are either male or you're female. Thank you very much.
Thank you so much. Going back to Dr. Kaliti, it's been 2 years, almost 2 years of since the policy was launched. What are some of the challenges that have been encountered in implementing this policy for the last, let's call them 2 years? What are some of the challenges being encountered in the implementation of this policy? Dr. Kaliti.
One, of course, the policy was a major shift because it focused on the actual meaning of the reproductive health and rights of Kenyans across board. So I don't think many people expected that, for the simple reason that we have been having a narrative of sort of extractive fictitious rights at the expense of others within the population. And that sort of changed because we looked at equitably, and we looked at everybody according to their age and what is provided within the Constitution. So with that, and you remember we had a policy that had been launched a little bit earlier in 2016, what was called the Adolescent Sexual Reproductive Health Policy, that had sort of neglected all the science and all the wisdom, and had gone ahead to sort of sexualize children from the age of 10 years with very prescriptive and very bold statements that are a little bit offensive to the Constitution and also to the culture of the people and the beliefs of the population, and more so to the rights of children themselves. So what happens with a policy is supposed to gravitate and organize and prepare partners and stakeholders to be able to fundraise, because it gives you the tool to say that this is the priority for the government for you to be able to raise money. So with the 2016 policy, there was a lot of negative money that was raised to the agenda of sexualizing minors and all that. So one of the major challenges I can say that you might have within the country is that there was a lot of that money that flooded the country, negative money that was coming to address the toxic elements that had been captured in that flawed policy.
Yeah.
So what happens with this kind of money, it can easily destabilize and derail the implementation of the actual policy. And you'll see that with a lot of busy people going to courts and all that, try to challenge all of that. It is still the same money that is trying to seep away, because when a donor gives you money and they tag it with the fact that your deliverable is to be able to make sure that maybe 1 million children aged maybe 10 and 12 years have contraceptives, you can imagine when you're pushing for that kind of deliverable within the population. It is, as much as it is sickening, but it is happening, and you need to be awash with that is a fact that it is happening.
Yeah.
So one of the challenges that you find that kind of negative energy, try to keep people busy from implementing the policy. Mm-hmm. The other challenge that might be there is because the policy itself, it needs to have several steps for being implemented. The first step is, of course, when you have a policy is just one document, and it's a process that we have not completed, because the policy is followed by what we call an implementation plan or a costed implementation plan. That costed implementation plan is the one that goes ahead to be able to not only publicize the policy, but also give technical support across the entire nation to be able to understand what are the contents of the policy, what is the new directive that we are coming on board, and what is the meaning within that. And I'll give you a very good example within the policy as we talk. Let us shift from these emotive issues that people discuss. We made a very bold statement and step towards making sure that there is quality, maternity care within the country. And we made a very simple policy direction that if any woman who is pregnant gets to any facility across the country, then within a stipulated time, that person has to be seen and a clinical diagnosis has to be made within a stipulated time. The policy, I think, says either within half an hour or to 1 hour thereabout. And there's a reason why I've picked on that. Because one, from evidence, we have realized that we are losing a lot of mothers, and most of them are being lost because they spend a lot of time within the timeline of seeking care within the hospital, to the extent that by the time they are getting that care, it's a little bit too late. Let's say, for example, a mother comes with a little bit of bleeding at 7 a.m. to Kenyatta National Hospital. That bleeding continues to worsen as time goes on. And within the queues and all that, she's not seen, she's not attended to. At the end of the day, by around 4 p.m., she's finally seen by a person who can make a decision on what issue she has. That could be maybe a medical officer, could be a consultant, or anyone who is justified to be able to make that decision. By that time, this mother might have lost almost close to 3 liters if she was having internal bleeding. And by the time we start running around, we had all the time to be able to intervene from morning until 4 p.m. At the end of the day, we may end up losing that mother, God forbid. And we said, she came to the hospital late, or she came yesterday, but the mother came in perfect condition. And we did an audit within facilities, and we found majority of the women actually come in when they're quite okay, but they walk out quite sick, or some of them do not manage to walk out because of those delays within the system itself being taken care of. So this policy was very bold and said that within a specified time, any mother, it does not matter the facility, is it private, is it public, a clinical decision has to be made. What does that mean in terms of policy, for example? It means that, number one, you will not open your facility to receive a mother if you do not have the capacity to make a clinical diagnosis. And a clinical diagnosis means, number one, you must have the correct skill, because not everybody can make a clinical diagnosis. There are people who are specially trained to be able to make that impression that this is the mother who requires cesarean section right now. This is a mother who needs this kind of treatment. This is a mother who is okay, I can go back. That kind of decision is not everybody who can make that decision. And then added time to it, added a lot of value, because it was going to trigger a revolution within the health system to make sure that for you to be able to align with the policy, then you are going to have the requisite resources anywhere where a woman can walk in to be able to seek care. So that was going to cut across. And those are some of the key things, that the big bites that if somebody actually took and ran with them, it would have sort of changed the way we were talking about maternal mortality in Kenya, the way women are dying unnecessarily when they're taking when they're seeking healthcare. And that is just an example to be able to tell you that some of the challenges that we have, because it needed to go to that extra step, develop an implementation framework, have a costed implementation plan, then beyond that, beyond the implementation strategy, then run with it and make sure you pacify the entire nation in terms of the counties and all the players to be able to understand what is required within the policy and they'll be able to implement that. So of course, finance is a major issue, because if, for example, you do not have champions who are quite zealous to be able to seek for the financing of the implementation of the policy, then it can also likely be able to, to gather dust if people are not keep it up and running. But this is something that instead of most of this noise that we are hearing, I wish people were quite busy implementing the policy, because it has quite broad prescription that can really give a lot of positive results for the nation if they actually implemented the way the thinkers of the policy and the way the nation actually thought when they were implementing it. So that is that's a challenge. The resources, the champions to be able to run with it, and of course there are other phases that were not developed And that is the implementation strategy and the coastal implementation plan. And of course, give it technical support and make sure that it is rolled out across the nation for people to be able to understand the content and be able to, to clear. Like what you're hearing, the noise here is because majority of the Kenyans have not been educated actually to be able to know what is the content of this policy and that it reflects whatever they wished. But you usually say that a lie can run across the world. I think, is it? By the time the truth puts its shoes, it's already gone around through the world. So that is where we are right now. That is the place we are dealing with as we speak.
Thank you so much. I think I'll also read what the area you've highlighted about maternal health care. The reproductive health policy states that every woman with pregnancy-related conditions must be clinically evaluated by a qualified, experienced, and registered nurse or midwife, clinical officer, medical doctor, or a gynecologist within 30 minutes of presenting to any health facility. I think that is the part you are highlighting, Dr. Kaliti.
Yes. And when it comes to a policy direction, for example, the first step was, number one, for facilities to be able to make sure that they can have that decision made, whether it is within 30 minutes, within 1 hour. Then after, as we get every mother to a decision to be made, because there are several layers for that, and that's why I'm clarifying that. The first step is to make sure that decision is made, because majority of them, the decisions are not made, and that's why we end up with a lot of complications within the facilities. So once that decision is made, then we go to the second level of audit, and that is to audit of those decisions, how many of them are correct, until finally, then you have the highest attainable standard of that care that woman can get, is where every woman, regardless of where she goes, the correct decision is made at the right time all the time. That is the ideal. That would be the highest. So that is a journey that sort of starts with a lot of investment in it at all levels to be able to make sure that this woman will be able to have that kind of, that kind of standard the Constitution was envisioning. Thank you.
Thank you so much. I would love to welcome listeners to post their questions on the chat section as we move towards the conclusion of this webinar. Dr. Mutua, I would love to address an issue that has been a big threat to, one, access to reproductive health services, and two, a threat to life. These issues are harmful cultural practices such as FGM, and also there are illnesses or diseases such as cervical cancer that have really been in the rise in these times. What does the policy state in order to deal with these two issues? The issue of harmful cultural practices such as FGM, and two, diseases or illnesses that are a threat to life, that are highlighted, that affects the reproductive health system of a person. What does the policy say about these two areas? Dr. Mutua, are you with us?
So basically, with regard to harmful cultural practices, and specifically, FGM, yes, the policy does mention and give a direction on that. But also the other thing also is to mention that the other harmful cultural practices are actually what one might call child marriage. I'm avoiding to use the word marriage with a child. You can't use those two words together, a child and a marriage. But those, we have cases whereby the children are taken off, to be wedded and all that. That is part of an harmful cultural practice. And of course, the policy, clearly elaborates that, it is in keeping with the Children's Act, so that of course, and marriage, of course, is only to somebody who is 18 years and above. In fact, even the Constitution of Kenya stipulates the same in Article 26, that marriage is of by adults. So by affirming that position of the Constitution, this policy speaks to that issue of harmful cultural practices. But of course, the other thing also is that specifically, it aligns also with the National FGM policy and strategy for the abandonment of female genital mutilation. As clearly, stipulated. I think it's even on your screens. You can see that it actually talks about that. So, and in fact, when you look at some of the indicators that are uploaded, by the service providers, by all facilities, whether public or private, there's an aspect that captures, again through the policy, that also captures the number of mothers who actually have FGM, so that then we are able to track. You can only track if you keep numbers. So we are able to keep track and say that in the year 2023, for instance, how many mothers who had FGM actually, came to our facilities. And therefore, we are able to pinpoint and know where those problematic areas are, so that then we can work together with other entities such as the Anti-FGM Board and all that to address those issues. And then over and above that is also what Dr. Kaliti has talked about, having healthcare workers who are skilled to make a diagnosis. A diagnosis is not just to say that somebody is pregnant, but you talk about that, yes, this person, that this mother is pregnant, or this mother is about to give birth. But you can actually go further and say, no, in addition to that, she actually she has FGM, female genital mutilation type 1 or type 2, or like that. So that is a complete diagnosis that captures that. And therefore, when you make that diagnosis, then you can put measures in place. And one of the measures, of course, there are some types of FGM, the very extreme ones, that somebody is not able to deliver normally. They would need to have a cesarean delivery, conducted. So that is part of what this policy talks about, ensuring that you have highly trained, competent people who are able to make, a holistic diagnosis on a mother. And when you talk about some of those conditions that can actually even, cause harm or even kill our mothers, it means that you make a diagnosis and say, yes, this mother is pregnant, she is 36 weeks pregnant, but she also has hypertensive disease in pregnancy, that she is 36 weeks pregnant, but she also has a cardiac condition. And you can also make a diagnosis and say, yes, she's pregnant, yet her blood levels are low. She has anemia. And in fact, one of the indicators that are captured in the antenatal care is to look at the number of women who are presenting to our facilities with anemia. So that then, even when you are making a diagnosis that this mother is about to deliver, you can even quickly know the blood levels, because there are some mothers, you cannot allow them to begin to go into labor without, let's say, blood transfusion. So basically, that's what it means. Having competent, highly skilled people who are able to make the diagnosis, and who have also been empowered, through various training modulations to be able to come up with this diagnosis. So basically, in a nutshell, that's the way I would answer that that question that you asked.
Thank you so much. As we draw to the end, Dr. Kaliti, I will ask 2 questions, then also refer to a question that has also been asked on the chat section. Question number 1: what is the place of local communities, Mwananchi, Wajiko, in this conversation, in the implementation of the RH policy? What is the place of the local communities in its implementation? Number 2, what is the place of community health volunteers in the implementation of this policy? And number 3, I think you can first answer those 2. Then I'll get back to the last question.
Thank you. The role of the community, again, let me put it very plainly, that a policy is not any different from medicine, the same way we do with standard medication. And I always say that the same way when you have malaria, we make a prescription that you have malaria, and then we give you chloroquine to treat the malaria and maybe paracetamol to take care of the fever and the headache. A policy is a prescription that is supposed to cure a problem that is affecting the population by the government. It is a government that is together with stakeholders, but of course, policy at the end of the day, the custodian is the government of the day. It is a prescription to try and cure a problem of the community. What does that mean? It means that everybody has a role to play. And a good example is that if you go to the hospital and the doctor makes a good prescription and you don't take the medication, then you do not expect yourself to feel better, because that is not likely to happen if you don't consume. And the only way we can do that is for the community to be empowered, to participate and hold the duty bearers to account. When, for example, the community is well empowered and knows what are the contents and what is expected in the new policy, then they play a role by being able to align and also being the people who can actually run with the policy, implementation process from the word go. And I'll give you an example. If the communities themselves, if the common mwananchi, for example, knows that if I go to a facility, it is my government, or the government has decided that I should be seen by somebody who is well trained and qualified to be able to do that, then you put pressure on the system upwards and it's able to change and respond to that. So the citizens themselves, they also become sort of activists for their own rights as prescribed within the policy. They do that because they know what is right, and they're able to know what is within them and what is prescribed by the government for them to be able to improve their health outcomes. That is one. But also the community itself, the Wanjikus and, the Denginas, name them. They are the people who are basically targeted with this policy. So they are some of the primary stakeholders within the policy itself. And if you ask me, it is impossible to run with a policy if you do not engage and involve them, because at the end of the day, it is going to affect them the same way it is affecting any other, segment of the society. So they need to have it, they need to know about it, but they are not technical, remember. And you need somebody who will be able to synthesize it for them in a very simple way that this is what you requested. Like when we went to them and we talked with them, their request was, number one, let us respect life. Let us, let us stop women from waiting for too long, or women from die within hospitals. Those are their major concerns when it comes to reproductive health. Now it's up to them to tell them, as we coin it into policy, this is what we are prescribing. This is what the government is wishing. This is the direction we wish to take, so that we'll be able to realize whatever you have asked. So that information has to come in very simple way that they can understand, and then they embrace it and they hold the duty bearers to account towards implementing the same policy. They can have a pull effect of pulling for the prescriptions or the spellings of the policy to be implemented from the grassroots going up. That is one of the community. And you asked something else about the role of another group. Yes, community health volunteers. Yes. Now, community health volunteers, I just want to let you know that the dispensation right now, we are moving and putting a lot of gas in terms of petrol, in terms of going to prevent or promote healthcare. And that is by design, because after we did all the numbers and economics, our economy cannot sustain a purely curative system, because curative is quite expensive at the end of the day. And we have been neglecting a lot of things that are pushy. Majority of Kenyans who are not supposed to be going into hospitals and we end up overwhelming our personnel and our resources and draining them when it is not necessary. So by going preventive, we are saying that now we are putting a lot of effort in keeping those who are healthy and preventing the majority of the people from going to hospital unnecessarily. And that's where the preventive bit comes in. We are not treating people at the community level. We are basically promoting their health and advancing their health. And here the community health promoters come in handy. Remember, we have 100,000 of them. We have mapped the entire nation, and each of them has households that they are taking care of. And these are the vehicles that are actually acting as the last link within the community. For those who remember, we're a little bit older, we used to have a similar system way back in the 1980s and 70s. And I remember when I was a young boy, nilikuwa na mashilingi, and this lady comes home and applies for me something for my mashilingi, and it disappeared. It was a lovely experience without me having to go for the minor things. And that's what we are saying now, the community health promoters. Within this policy, there is a lot that needs to do in place of, and I'll give you a good example. If we are able to align the community health promoters, there are powerful platforms to be able to advance some of the takeaway messages within the policy itself. Number one, they'll be able to pass the correct information if we give them that information that you need to go to hospital and you see ABCD. Then number two, remember, we are given kits, and these kits have very basic things like, measure the blood sugar, being able to take blood, the blood pressure. You can imagine if the community health promoters, they are well equipped to be able to know that if at all you take the pressure of a pregnant woman and you find it is elevated, then that is somebody you need to empower to be able to seek care immediately. So it's a very powerful platform of being able to implement this policy if they know, but it has to be digested to them, taught to them, and then they pick what is at the primary level within the policy for them to be able to run with it and be able to empower the population to be able to draw down the benefits of what is contained within the policy. So they have a huge role, and it's a huge platform. In fact, from where I'm seated, if I was, for example, if we were to get busy a lot, anybody who is speaking within the space of reproductive health, the cogs of this one or that, those are the things that are supposed to be keeping them very busy. We have community health promoters here. What is it that we can pick from this policy? They run with it to the household, and we make sure that burden is taken care of, such that when you are getting your women upstairs, when you are getting these girls, whatever, with crisis pregnancy upstairs, they have already been done the simple mapping, and they have been referred appropriately because they know care is there, and they don't have to end up in the hands of quacks or in backstreet doing things that are driven by monetary gains, and people may not be having their best interests at heart. And that's a very huge platform that can be used in terms of mobilizing for the support and being able to actualize the small pieces at the grassroots for this policy.
Yes, thank you so much. I want us to conclude the session since it's already 9 p.m. Maybe one question highlighted on the chat section. Good evening. My question is with respect to the realization of socioeconomic under Article 43, reproductive health care provided therein. The Supreme Court of Mitubel case was profoundly held to finality that it is a constitutional obligation of the state to progressively realize such rights, including reproductive health care included. This can be done by states taking supportive measures. It is arguable that a major challenge to that is the implementation by the state, not absence of law. To what extent has the policy cured this? Dr. Kaliti, have you understood the question? It's heavy on legal language. Dr. Kaliti, have you understood it?
Sorry, I'm trying to read to understand it. I've had to log out, but I was not getting exactly what the writer is asking. Or if the writer is in the room, maybe they can go live so that we can answer their question.
Odindo Yoga, are you around? I think due to time, we'll proceed with the next question.
What is he asking? What is he asking?
I am also not sure, but I see Mr. Kaketo has answered him. Odinda Yoga, the concept of, I think he has understood that. The last question, Uganda adopted the Women's Optimal Health Framework recently. What do you think? Should Kenya do the same? Should we adopt the women's optional health framework? I think it's highlighted in the reproductive health policy. So maybe Jada can go through our policy. There are some key areas that have been highlighted in regards to that question. And from that, I think we'll just conclude the meeting. Thank you so much for all the participants who have joined the meeting. And more thanks to the panelists, Dr. Gideon Motua. Thank you so much for joining us, and Dr. Kitili. Thank you so much for your insights in regards to this discussion. This discussion proceeds. We'll continue with this discussion in our live symposium this coming Wednesday, where these and many more conversations will come up and will be addressed by different panelists who are not able to join us in this webinar. We welcome all participants to join us at the live symposium that will take place at the Cardinal Otunga from 8 a.m. in the morning on Wednesday, the 20th. All participants are welcome, and we are hoping to see you there and even continue furthering this conversation in that day or in that session, in that event. Thank you so much for all who have attended the webinar. We hope it was insightful, and we look forward to more engagements in the future. Have a good evening. Thank you.
Good evening too. Thank you, everybody.